Thank you, Professor Kwan Lee, for the introduction, and sorry for owner speaker because I have to take the first presentation as I have to fly to Hanoi. So my talk is about the application of ECMO in our clinical practice for cardiogenic shock patients. So first questions, does ECMO have in our cardiogenic shock? As Professor Kwan Lee mentioned about this one, we spend a lot of money and resources on terms of saving life for the patient in shock. Unfortunately, our multiple RCTs like AI PB shock in 2020, then ECMO CS, ECMO shock 1, ECMO shock 2, LCNS in 2010 also demonstrates that there's not so much benefit in terms of using ECMO for cardiogenic shock patients. So if you look at the ECMO CS, the on-cause mortalities are quite similar between the ECMO patients and the conservative patients. ACLS shock 1, we have a look at the on-cause mortality the same, the single center, 42 patients, AMI cardiogenic shock, ECMO versus standard care, and you can see that the p-value is insignificant, so meaning that we can choose either standard care with medications or ECMO device support. Unfortunately, the most all the trials with shock patients, the recruitment of the patient is very tough problems. In Euroshock, if you look at the number of patients quite low, 35 patients with AMI shocks, and they also compare the ECMO versus standard care. And you can see that the 30 days mortalities are quite similar between them. The shock 2 also, no matter the number of patients is bigger, about 417 patients, the same, compare the ECMO and standard care, there's quite similar results between them. So we cannot see any improvement in terms of the management of the patient with the shock. So if we look at the more data, the bigger data, about 567 patients in cardiogenic shock because of AMI. Let's compare the ECMO and standard care. You can see on the left-hand side, the VA ECMO, and the right-hand side, the VA ECMO was. And you can see that the line is lie in the between. So meaning that we don't have any benefit from ECMO supported patient for cardiogenic shock treatment. So the answer is quite clear. Currently, we don't have enough scientific and clinical evidence in favor of ECMO in CS patients. So my next question is, can we keep doing ECMO in CS patients? Let me start with a case presentation. This is a 62 years lady patient presented with a chest pain, started 3 hours before hospitalizations with a very severe condition, BB low, 80/50, SpO2 only 90s. The patient was diagnosed, as you can see on the EKGs, as the elevation in AVR. STEMI, we load patient with ticagrelor, aspirin, and transfer to cath lab. Unfortunately, during the waiting time in the ED, the patient was collapsed. We start CPR, intubated, shock because of VF, and luckily, patient returned to the sinus rhythm after 10 minutes of support, and then we transfer to cath lab. As you can see on the cath lab, the lab main was occluded, and that is the reason why the patient got a cardiogenic shock. The RCA is minor disease. And with the hemodynamic support, we start to change to the femoral access, sit for ECMO support, and insert IABP and ECMO together for the patient because she's quite young. And after that, we stand from the LED, the left main to LED is quite good. Unfortunately, the thrombus in the LED and diagonal. So we put the stand in for the patients. The flow is quite good, no matter the result is not as 100% as we wanted. But thanks to the ECMO and IABP, we are very calmly do the procedures because we have the organ support. So we did it very calm and did our techniques quite good. So this is the final result from our study. The patient was discharged from hospitals 1 week after that. So let's talk about why this patient is not, as a result from clinical trial, is not so good, because most of the cases in clinical studies, like in ECRS shock, euro shock, or ECRS shock 2, the number of patients with cardiac arrest is a lot. So if you look at the hemodynamics in the AMI cardiogenic shock patients, you can see that the output in the patient with on-car is quite bigger, and then the SpO2 also in the patient with on-car is higher. So the main reason why we have patients die after this, for the non-on-car patients, the most of the cause is cardiac failure. But for the on-car patients, the most problems is due to brain, because we have to support. That is the reason why in our department, the most important we ask our staff is train CPR almost every week. So the rationale for use of ECMO in CS patients, for most of the cases, severe cardiogenic shock, threatened with multi-organ failure, who are irresponsible for the vasal pressures, and inotropes, and circulatory or respiratory support. When we need the bridge to allow the time for the cardiac to recover, and for reverse patient, either using the PCI or surgery. Or sometimes we can do the vet patients. We did the first case in our country with the heart tree and heart transplants. Now Dr. Professor Ding also doing this program very well. So we have the chance for the patient to recover after this. And when we see that the patient also got respiratory and circulatory failure, ECMO can support both of these cases. And actually, in the setting of ECMO Experience Team Center, with the careful anticoagulation management and close monitoring for the communication, we can optimize the benefits and minimize the risk. In our center, we start our program ECMO for the CS patients in about 20 minutes. We finished the ECMO insertion. This is some of my clinical case for you to see. The patient, after diagnostic angiogram, the left main stenting was put in. Unfortunately, the very acute left main thrombosis, and patient collapsed. And this is how we did. We insert the ECMO, and we did the stenting again quite calmly. And you can see that the patient can, this is the second patient, also left main and the RCA occluded, causing cardiogenic shock. And we insert ECMO. You can see the patient can talk to us during the procedures. We don't need to intubate him because the supply for the organ is quite good. So I just want to present my study with my young fellow who presented for Young Investigator Awards this year. We try to do the awake via ECMO or sedate via ECMO in cardiogenic shock. And this is a study we extubate on the patient within 48 hours after the intubation, after the, if we intubate the patient, and avoid intubation if we can. Overall, we have done 96 patients. Among them, awake is 38, and sedated 55. And you can see that for the sedated patients, the result is quite good. I don't know why this changed the font colors here, but you can see the mortality survivor in our awake patients quite good. 62% is quite good, and but for the sedated patients is not really good compared to the awake one. So our recommendation is that if you want to try to ECMO program for CS patients, should do with awake ECMO. With that, I thank you very much for attention, and I have to leave the conference now. So thank you, Prof. Kwan Lee, for leading this conference. Thank you.